Let me officially welcome every one of you and especially Dr. Gauhar Afshan on this forum. I am very excited tonight because Dr. Gauhar is not only my mentor and supervisor and teacher, but a very dear colleague of mine. I was her resident and then her fellow in pain management. So it is a moment of pride for me as well that she is tonight online and teaching us something on pain management with ketamine, its safe and effective practices. So let me, and because today is the last lecture of this, not only this season, but also this year. So I'm really grateful to Dr. Gohar that, and I'm really excited that we are ending this year on a very good note with, along with Dr. Gohar, that she is with us. So we welcome Dr. Gohar to this forum of PSA Online Lecture Series. And let me just give a brief introduction of Dr. Gohar, even though she doesn't need that introduction. She's beyond that introduction, but let me give a brief introduction of her. Dr. Gohar has done her FCPS in anesthesiology from CPSP in 1996, doing residency from Aga Khan Hospital, after which she did her fellowship from Queen's Medical University, Nottingham, UK, 1998. Afterwards, she came back to Aga Khan University Hospital, and ever since she has been remained in the leading roles. She is leading the pain management department at AKU Karachi. She has always remained the executive member of South Asian Regional Pain Society, immediate past president of South Asian Regional Pain Society. She is also a member of IASP, which is International Association for the Study of Pain, executive member of Pakistan Society of Anesthesiologists, Karachi chapter. She has also remained the president of Pakistan Society, STSP, which is the study Pakistan Society for the Treatment and Study of Pain, Sindh chapter. And she currently is endowed chair at Aga Khan University Hospital since 2011. So I welcome Dr. Gauhar Afshan to tonight's lecture. Dr. Gauhar, thank you so much for joining us, and over to you for your lecture. Thank you, everyone.
So, thank you very much. Can you hear me?
Yes, we can hear you.
Yes. Thank you very much, Asma, for such a kind introduction. I can't tell you how excited I am just to listen everything from one of my favorites, one of my favorite trainees, and certainly now as a colleague, Asma Abdul Salam, who is really academically charged person, and I'm really grateful for this platform, the PSA, which actually started this series. And I think it started under the, when Dr. Asma was the general secretary of the PSA Karachi, she started that, and still she is doing that in spite of all her, busy professional activities. And certainly she is also, still she is looking after her professional developments, and she's, mashallah, doing the PhD, one of the, that I'm really grateful and I'm proud of you. So the topic, when Asma told me a couple of months before about this, session, so I was excited, but I wasn't sure what topic I should take. In the current, although I'm still busy, I still doing, practice in anesthesia, but my main focus is the chronic pain. But I also know that the PSA is a forum where majority of anesthesiologists, they are, doing right, left, and center all kinds of surgeries in ICU. Then certainly, whenever we talk about the anesthesia, pain is always there. So I thought the topic should be in a line of their, the PSA vision and mission, that the anesthesiologists working in Pakistan may get benefit of this. So ketamine, because the ketamine is currently, in academic journey, normally we also try to get new knowledge, new things. So currently, in the last couple of 2 or 3 years, I'm working hard on the two areas, and this is actually the opioid alternative, the cannabis, initially the cannabis, and still I'm working on a cannabis, and secondly is the ketamine. So the my passion for this today's talk is basically, I just want to share that how we can see this ketamine as an alternative of opioid. And my purpose is just to try to cover two or three aspects, because it's not possible that in 30-40 minutes we cover everything. So I am very focused, and I determine some of my own objective, and I will share with you. So I have no conflict of interest as far as this today's presentation is concerned. So what I will talk about in the next half an hour is about ketamine. I know majority of this forum participant, they are very well known about the ketamine, as and because in anesthesia it is one of the very famous drug, and we have been using it for years and years. Then I'll talk about the mechanism of action of ketamine, especially in terms of when we talk about the ketamine in pain management. I will share some of the literature and the web searches for analgesia and pediatric population. Unfortunately, if you just Google that and all types of web search and literature, you will hardly find good articles, I mean, critically appraised good articles in pediatric pain population. Uh, we will hardly get guidelines for the pain management in pediatrics, but somehow in pediatrics the pain management is neglected, or people are, they have fear to, treat with them with the opioids, and there's so many reasons. So literature don't show much about this ketamine or the pediatric pain, not in the ketamine, but the pediatric pain, the guidelines and everything. If you see the commonest currently guidelines in practice, the NICE guidelines, the American Society guidelines, all these things, you just see that even in all these areas, you will not find the specific guidelines on the pediatric pain management, and you can extrapolate from some of the other guidelines available. But we should remember that the sometime we have to extrapolate, but this is not so simple sometime in a case of pediatric, where we believe that the pediatric population is not simple the small adults. So there are so many other things. So we have to be careful. Then how would you apply some of the knowledge that is available in literature on adult population to convert into the pediatric population? So this is one of the limitation for this problem. So main of my question, which I'm trying to answer at the end, is about, can it be used as an alternative to opioid? Which is, I told you that this is currently my area of interest, that I am looking after an opioid alternative, whether it is cannabis or the ketamine, and that's why this today's I'm presenting. And some of the concluding questions, which actually it was my questions initially a couple of years back, and now I have found the answer directly from some of the literature, or some extrapolation from available literature. And certainly the last is the concluding remarks. So first thing is that ketamine is a versatile. We all know that it's a versatile established in aesthetics. We all know that. It is in practice for maybe more than 50 years. It produces the distinct state of anesthesia known as dissociative anesthesia, in which patient may appear awake, but actually patient is unresponsive to surgical stimuli. And that is the beauty of this dissociative anesthesia. But recently, I mean, I'm talking about last 2 decades mainly. Recently, there has been increasing use of subanesthetic doses of ketamine to provide analgesia in various kinds of pain, especially the perioperative pain, acute pain. My today's focus is only on the perioperative pain. I'm not going to talk about the other pain, the neuropathic pain or chronic pain, because that is not the focus. So we are considering this is a PSA platform. The anesthetics are mainly available, and everyone, anesthetized pediatrics population. So maybe this presentation would help them. This is a very important to remember that if you just see why I'm saying that the ketamine has the qualities of an ideal opioid or near ideal opioid alternatives. Now, although ketamine is a phencyclidine derivative, uh, but if you just see the 4 characteristics that may make it ideal opioid alternative, it is a potent analgesia, and this is based on the current literature, whatever available. It causes the minimal intrinsic respiratory depression, which is a problem in the opioid, whenever we give opioid, one of the fear is about the respiratory depression. And it has a most favorable hemodynamic profile. We all know that when the patient comes with the shock and trauma and all these things. So normally we know that this is a medication which can provide the favorable hemodynamic profile. And whatever adverse effects happens with this, they are manageable and they are short-lived. And that is most important. The manageable and short-lived. And because of these four qualities, this phencyclidine derivative you can consider is an opioid alternative. And this is I'm talking about theory. And now let's see what the literature says that. So how this ketamine, what is the mechanism? How does it work? We all know that even when we were medical student, we read about NMD receptors, and when we were doing residency, then and a lot of things coming up with the ketamine is about the NMD receptor antagonist. So we know this is the one of the way how it acts, the ketamine. Ketamine blocks the NMDA receptors, which are involved in the transmission of pain signals and the development of central sensitization. We know currently the one of the area very, very important and emerging area in pain is about the central sensitization. A lot of research is being done. Is not only in the adults. We know that even in pediatric population, if we don't treat pain at the right time, then it may end up with these chronic pain or because of the central sensitization. So this is one of the things that prevent to develop the chronic pain in all kind of acute pain patients. By inhibiting these receptors, ketamine reduces the transmission of these signals and prevents the wind phenomena, which is very, very important in central sensitization. Then ketamine, if you see, it also modulates the descending pain pathway. We all know that currently we are talking about enhancing the internal physiological mechanism that persists in the body, whether it applies to the cannabis receptors available, or now they currently this modulation by the ketamine, that the ketamine, when you give ketamine, it enhances the descending inhibitory pathway that suppresses the pain signals in the spinal cord and helps the modulation. This is a very unique, function of this modulation of the ketamine for pain management. It also inhibits hyperalgesia and allodynia. Again, by preventing central sensitization, the ketamine reduces the hyperalgesia, which is exaggerated pain response to painful stimuli, allodynia, and both of which are very, very common in chronic painful condition. But remember that when we're talking about chronic painful condition in continuation of the acute pain, then that may happen in all these cases. So acute post-operative pain, or especially in pediatrics population, after scoliosis, after major thoracic surgeries, these are reported that the even the pediatric population can develop the hyperalgesia and allodynia. Then ketamine also, this is again a unique property that the ketamine also acts with the other receptors such as opioid receptors, nicotinic receptors, muscarinic receptors, which can contribute to its analgesic properties. So it enhances the if somebody is on opioids, then it enhances the effect ketamine effect on the equipotent doses, and we can reduces the opioid consumption. And a very unique phenomena which is not available in other pain medications like in opioids is anti-inflammatory effect. So the ketamine also has anti-inflammatory properties which can further contribute to its role in reducing pain, particularly in inflammation and pain conditions. So we can see there are so many ways how the ketamine is actually used for pain. So, in summarize its mechanism of action, that ketamine is an NMD receptor antagonism, so it will prevent the pain signals to go up. It has got anti-hyperalgesic effect. It's also the opioid sparing, because when you use the ketamine with the opioid effects will enhance and the opioid demand or opioid consumption may be decreased. And very unique property of anti-inflammatory action and the neuroplasticity. So these five, if you just five mechanism of action, which is like proven mechanism of action, we can say that the ketamine is a valuable and versatile in the pain management. If you see currently available pain medication, we talk about opioid, you talk about non-steroidal anti-inflammatory medication, you talk about anticonvulsant. So none of these medication has so unique 4 or 5 mechanism of action that just has central affection, how it is affecting the central system, the peripheral system, the anti-inflammatory system. So in that way, the ketamine role, considering these 5 mechanism of action, is unique. And so that's why we should not ignore its role in current medical practice. We all know that, and this is now coming to the practical grounds. We have talked about the mechanism of action, the possible mechanism of action, which is scientifically proved. Now, coming to the our approach to pain management, we all know that in a very famous WHO analgesic ladder, I think all of us, I think, sitting on this platform, we all know that the WHO analgesic ladder, how it guided us to take patient through the safe approach for pain relief. So, if you just see the W Health Organization uh, actually made this ladder for the cancer pain management. But somehow anesthesiologists and the World Federation Society of Anesthesiologists, they thought a lot about this, how we can change this modern thinking about the ladder approach, that is, when should we do first, and then the second and the third. So they changed this ladder to acute pain. And how does it shows that? If you, this is very important, that when we talk about cancer pain, then this is the step ladder, escalating step ladder. We have to go from mild pain to moderate pain to severe pain, and this is the WHO ladder for cancer pain, which has to escalate. So always start in cancer patient some the non-opioid analgesics, then non-opioid analgesics with opioid, the mild opioids, and then the third steps. But in acute pain, there is a, you can say, the downfall. So you have to start with the maximum medication, especially I'm talking about acute pain. And WFSA, the World Federation Society of Anesthesiologists, thought through this WHO analgesic ladder, and this is the new picture, that is, this is for cancer pain, this is for acute pain. And this apply for both the acute, the adult population, and the pediatric population. Okay. Oh. So, so what is the philosophy of acute pain relief in pediatrics? So the philosophy, and this is very important to understand, the what is the philosophy. So philosophy of acute pain, especially we're talking about the post-operative pain, emphasizes the principle of compassion, individualized care, and evidence-based practice. So individualized care is very important. There is no single formula applied for everything. So these baseline knowledge, certainly you have to make a customized plan for any pediatric population. There is no one formula that you just apply to. Yes, the principles you can remember, and then the application, the time of application, you have to make a individualized care plan. So this is important, that the children are not simply small adults. Their unique physiological, emotional, and developmental needs must guide pain management strategies. Pain relief should be proactive, and this is very, very important. It has to be proactive, aiming to prevent pain through combination of pharmacological and non-pharmacological interventions, and ensuring the safety and efficacy by balancing pain relief with the minimal side effect, using age-appropriate medication and techniques. So this is, if you consider this philosophy that the children are not simply small adults, so we have to see the changes in the physiological, emotional, developmentally. Then it's also important that it has to be proactive. You have to anticipate that, especially in the acute pain, what's going to happen with the child, and ensuring safety and efficacy. So you have to balance. Pain relief is very, very important, but not at the risk of the side effects. So you have to keep a balance, then the minimal side effect and the good pain relief. This good pain relief and the minimal side effects. This philosophy ensures that the pediatric pain management is based on the compassionate and comprehensive, promoting recovery and minimizing the long term of the consequences. Now, this is very important that somehow, uh, whatever the current situation is here, not I'm talking about Pakistan, everywhere in pediatric population, somehow in the pediatrics, there's a poor control of pain. And this is poor control of pain is a significant concern across the world. In the pediatric population, pain is, there are so many things why it is under recognized and inadequately treated. But you all know that one of the very difficult thing is the pain assessment. Even in pain assessment, in the adult is a problem. And but in the pediatrics, the pain assessment is difficult. And if on top of that, if you are not ready to give, individualized care or plan or medication for pain control, this is very, very difficult. And the poor pain control is a significant concern across the world in pediatric population. But that's not my focus of about talking about the pain assessment and difficulties and challenges here. I'm just talking about one of the factor for poor control pain is the pain assessment, and on top of that, the medication availability and all these things. So if you see the what is the prevalence of poorly controlled pain in pediatric population, so it is number is alarming. Approximately 20 to 40% of children report moderate to severe pain after surgery. And the chronic pain transition is 5 to 15% of the cases. But the literature is very, very scanty. So it may be under, reported. We can't say that this is the most likely, but whatever available, it is 20 to 40% in limited literature says that the pediatric population report this pain, and 15 up to the 15% these pain may convert into the chronic pain. In emergency setting, which is a very, very alarming number, emergency setting when the kids come for after trauma, after fall from a roof or road traffic accident, that's a terrible, because in children normally people are really reluctant to give any medication in emergency, and in emergency this kind of control is about 70%, 50 to 70% of the children in emergency department, they don't get anything because of this fear that patient might get get respiratory depression, or might get bleed more. So the non-steroidal and opioid, they all these the normally these kids are deprived of these common medication. So remember that even in kids, we know that they are not small adults, but we should remember that we cannot make them, we have to make them pain free. So no pain, please. So this is a very, very important that the pediatric population, apart from all these physiological changes, your fear of, having respiratory depression or a problem, still you have to plan something according to whatever available in your setup for the pain relief in pediatric population. So what are the different barriers that actually makes this situation is difficult? So one is about the fear of opioid use. One is that opioid use, the people are reluctant. If you use in pediatric population opioid, then they may end up with the respiratory depression, and they may end up in going to the ICU or a special care, or delayed in recovery, or delayed admission, and all these things. So this is one of the issue. But in certain places, there is no opioid available for this pediatric population. So non-availability of opioid is also an issue in pediatric populations. Then one thing which I already told you about the child's ability to express pain, which is a thing, a universal challenge for everyone. Then misbelief that the pain is an inevitable part of the surgery, leading to the acceptance of untreated pain. The lack of pediatric specific pain guidelines and protocols across the different societies and countries. Limited training in pediatric analgesia. No one know, even in pediatric surgery fellowship, this portion, the pediatric analgesia, this is neglected. So the curriculum covering the pediatric analgesia everywhere, not in anesthesia, but even in the pediatric population everywhere, it really is the and the lack of awareness about the good pain relief in considering the overall outcome. So if you just see these different challenges, so don't you see that a simple medication which has a very proven mechanism of action, can produce the pain of, for example, even the trauma patient. If the pain, if you are reluctant about hemodynamic stability, or you are, avoiding opioids because of respiratory depression. So certainly, what is the role of ketamine? Can we use in ketamine and produce the pain relief without this fear of hemodynamic instability, without the fear of respiratory depression, and so on and so forth. So this is important that in emergency situation where the inadequate pain control is up to 50 to 70%, this kind of a rational use of ketamine, how it helps. So ketamine, now coming to this a limited literature which I found it. The ketamine plays an important role in pain management and perioperative pain control by providing rapid and effective analgesia. And again, this is important. It produces a rapid analgesia. The onset is very quick. Its primary mechanism, I already told you. I'm not going to repeat that. It's particularly useful for managing surgical pain and preventing the transition of acute pain to chronic, and the low doses has been shown to improve post-surgical pain control, inflammation, and enhance the patient recovery. Now, effectiveness of ketamine compared to opioid analgesia, that's a very, very important area. And there is a very important one systematic review published recently in 2022. And the purpose of this systematic review is to see whether the ketamine analgesia is comparable with opioid analgesia. And in terms of only the efficacy, they were not actually looking, the primary objective is just to see the efficacy, and secondary objective is just to see the safety. So existing evidence indicate that a low dose of ketamine is as effective as more commonly used strong opioid analgesics. And this systematic review, the ketamine, the papers who actually compared the ketamine with fentanyl or morphine, they found that they are equipotent in terms of pain control. And they, in this systemic review, actually, there's a very stringent inclusion and exclusion criteria. So there only 4 studies were included in this systematic review. Although to begin with, they found 57 studies, and they keep removing them. So in this systemic review, they found that commonly dose of ketamine, which is 0.1 to 0.3 milligram, this is subanesthetic dose for pain relief. They were used for pain relief compared to fentanyl and morphine. And fentanyl and morphine dose is the same as it is recommended for pediatric population. And although in some of the papers, they also used continuous infusion followed by this bolus, which is a 0.1 to 0.3 milligram. And they find that the pain relief after the morphine bolus, or after the fentanyl bolus, or after the ketamine bolus, they are equal. So from this systematic review, they mainly focus on the pain relief after the bolus doses. In some of the papers, they also use continuous infusion of 0.1 to 0.2 followed by the simple bolus. The side effects like nausea, dizziness, and dysphoria, the people actually concerned about dysphoria. Fortunately, in this systematic review, they found all these side effects, the nausea, the dizziness, the dysphoria, they're self-limited and very short-lived. And there was not required any action or any treatment for these side effects. It was self-limiting, it automatically goes away when the peak effect wears off. So that is very reassuring that this systematic review support that the ketamine pain relief is as equal. I'm not talking about as a co-analytic. The systematic review actually says that if you cannot if you don't have opioid, or if you cannot, because of some reasons you are not comfortable using the opioid, then the ketamine, this dose of ketamine would provide almost the same analgesia as the opioid, fentanyl or morphine. which is very reassuring, and the side effects are very short-lived if happens. And not in all cases, at the 17% of the cases, when there is some kind of a dizziness or nausea, but the nausea and dizziness, that is also the common side effect of morphine and the fentanyl. Though this is not unique as far as dysphoria is concerned. Again, in the pediatrics, this is very difficult to assess, but if it happens, which is apparently very short acting, it is short limiting. So this is very important guidelines which I found it that was published in Journal of Anesthesia in 2020. It was actually by the various pediatric anesthesiologists, but is not, and it is promoted by later on by the NICE guideline, which is the British Society. So it was not initially started on the NICE guidelines, but it was supported by the NICE guideline. And in this guidelines for TDRD, the ketamine can be effective as an IV infusion, either as the main agent or in combination with opioid or other analgesics. So in these guidelines, other than the American Systematic Review, which I just talked about, here they said that the ketamine can be used as a solo agent, but it can be used as a co-analgesics with the opioid. And the typical analgesic dose here, they talk about in 2 to 4 microgram per kilogram per minute. Somehow in this guidelines, they are not talking about a bolus dose as we used to give, or it was or an American kind of a guidelines which we just talk about that. But if you just see this 2 to 4 microgram per kilogram per minute, it actually comes like zero point 0.1 to 0.24 milligram per hour. So it is 0.3, 0.1 to 0.3 milligram normal bolus is comparable here. The limiting side effect is dizziness or sedation. And at these doses, the hallucination and vivid dreams are not observed, which is because they claim that the dose is less than 0.3 milligram, and it is not the bolus form; it is infusion form. They said they would avoid the hallucination and vivid dreams. But certainly, even they recommend that the APS visit, acute pain service visit, must see all these things. Then this is now I'm talking about the third and the last available guidelines which I found. So when we talk about that the ketamine just as an alternative to opioid. In the second guidelines, which is supported by the NICE guidelines, that the ketamine as a simple analgesics in children or as a co-analgesics in children, the doses are different from the first guidelines. And this one has 3 recommendations. The pain management in children should be based on the principles of multimodal analgesia. They said it should be the part of the multimodal analgesia. They are not asking them as a solo agent, which is initially the first guideline says that. And we all know the multimodal analgesia is a fundamental principles of pain management. I know everyone is practicing multimodal analgesia in adult, and they are very familiar that what the multimodal analgesia means is that. So I'm not going to repeat that, but just remember that the multimodal analgesia, the synergistic effect of different analgesics ensure the effective analgesia and thereby minimizing the side effects. In these guidelines, the second recommendation is that the non-opioid analgesics should be used for pain management in children. So first thing that the multimodal you have to plan in children, and the non-opioid, we talk about that apart from the 3 common non-opioid, one is the ketamine in these guidelines. The other 2 is lignocaine and gabapentin. Ketamine, then another recommendation, the ketamine may be used as co-analgesic for pain management in children. So again, this guideline says that the ketamine can safely be used as a co-analgesics in children. So maybe you are not use the ketamine as a sole agent, but whatever you plan, then in that planning, individualized care planning, you can add the ketamine just to decrease the consumption of opioid, decrease, considering the principle of multimodal analgesia, so everything would be decreased, and patient the pediatric population would get a good pain relief with minimum side effect. Ketamine as a co-analgesic, we all know that when we talk about the multimodality or multimodal analgesia, this is important that we remember the 5 a possible mechanism of action of ketamine, and we talk about the five mechanism of action of protein, then we can beautifully fit the ketamine as a co-analgesics. So what I would like to take the, whatever message you get it at the end of this session, is that the five mechanism of action of ketamine. If you remember that five mechanisms of action, certainly you would promote the ketamine in your practice. If you see the dosing in the literature, the dosing is, as I told you, in the three different guidelines, the doses are a little bit of difference, but not much difference. So the concept is certainly that zero point 0.1 to zero point 0.3 milligram is a single bolus dose, followed by less than zero point 0.1 to zero point 0.3 milligram, just to consider 2 to 4 microgram per ml infusion. So it all depends what type of surgery you are actually handling, because not in every patient. For example, if you are planning the post-op plan or intraoperative plan for scoliosis surgeries in pediatrics. I mean, this is the surgery that typically you have to use this kind of a ketamine to prevent the chronic pain and to have a good recovery. And this is a beautifully fit this ketamine. But certainly the very small tonsillectomy, no, there's no need of giving ketamine. But whatever surgery is more than mild pain, it has to consider. Three routes are mainly advisable. In Pakistan, we are using mainly the intravenous. When I was a resident, then I have seen using ketamine intramuscularly. But since I'm doing my own practice, I'm using the intravenous ketamine, not the intramuscular. The nasal and oral, yes, we are also using oral route, but there's not available in Pakistan. But you can ask if you're working in a big hospital and you have a pharmacy department, then certainly you can ask your pharmacy people to dispense this ketamine for oral route or oral syrup. So if you see the safety and side effects, because in whatever literature we have is as far as the meta-analysis is concerned, and some of the papers over the past 35 years, ketamine has consistently demonstrated its safety and efficacy in children. So we don't find anything which actually restrict us not using this in pediatric population. Its broad therapeutic dosing range, cardiovascular support, presence of respiratory preserves of respiratory function, airway reflexes make it a compelling choice compared to the other non-opioid options and the opioid options. It is important to note that the ketamine is a non-reversible agent. And this is important because if whatever medication you use, when you use opioid, opioid can be reversed. When you use midazolam, so there are some medication which can be reversed, but this is a non-reversible agent. So if you just use with caution, with the range which is recommended, so this is a very, very safe medication. So before I conclude, I would like to answer the three questions which was common in my mind when I started working on ketamine 3 years back. So one of my question is about for the ketamine, that which acute pain condition should be considered the ketamine in children. So this is important, that upper abdominal and thoracic surgery, do major surgeries, if you are handling the major surgeries where the greatest benefit is to opioid reduction. And this is important, that all kinds of orthopedic surgery, the limb and the spine surgery, this is a very good option, the ketamine addition. Ketamine as a solo agent, if you are working in a setup where the opioids are not available, or you have some kind of fear of managing post-operatively with the opioids, so the ketamine is a very good option. Although the patients undergoing surgery with expected mild levels of pain, as I mentioned earlier, the tonsillectomy head and neck, there is not a much promising, outcome change with the ketamine. So yes, you can use it simple, non-steroidal. There is no need of this ketamine. What dose range is considered sub-anesthetic? That's the question number 2. And does the evidence supporting dosing in this range for acute pain? So the ketamine produces the analgesia at the plasma concentration of 100 to 200 microgram per ml, which represent a small fraction of plasma concentration which we use for general anesthesia, which is 9,000 to 25,000 nanogram. So the side effects or the bad thing which is associated with the ketamine is basically for the 9,000 to 25,000 nanogram ml serum level. So how can 100 to 200 microgram can produce the dysphoria and others and central system side effect which people are worried about. So considering this serum levels, and again this is the good evidence for your practice that 100 to 200 microgram, if you're using the zero point 0.1 to zero point 0.3 microgram, it will never go more than 100 to 200. So you should not be worried about, although still the monitoring is
Progress
advised.
is advised.
So the common subanesthetic dose of ketamine used in clinical practice, as I mentioned to you, is about zero point 0.3 to zero point 0.5 in some of the center. Majority in our part of the world, we are using is 0.1 to zero point 0.3 milligram per hour, depending on the analgesic response required for that particular patient, because the individualized difference certainly matters. It is recommended that the ketamine bolus dose don't exceed zero point 0.3 milligram. And this is important because when we talk about the safety, so we have to know what is the maximum dose. Beyond that, we should not use that. The last thing which always, I was thinking that can we use this ketamine in the patient control analgesia? And the evidence is very, very limited for the benefit of IV PCA, delivered ketamine as a sole analgesic acute pain. But some of the literature shows the grade C recommendation. But certainly the grade C recommendation, you have to be careful in practice, especially in our part of the world, where some of our allied health support is not as good as in the other part of the world. So IV PCA ketamine is certainly not recommended in our part, although there is a evidence grade C recommendation for that. So after giving these three questions answer, I would like to close by these concluding remarks that the ketamine possesses, this is very important to remember, the ketamine possesses many of the qualities of an ideal opioid alternative. It recognized for its analgesic and antihypertensive effect and has demonstrated the ability to reduce the postoperative pain and decrease opioid consumption. So you can use it as a simple analgesic, as a solo agent, or as a co-analgesic with the opioid consumption to reduce opioid consumption. The current evidence suggests that the ketamine may play a valuable role in pediatric pain management as analgesics or co-analgesics, although because literature is scarce, so the further studies are needed to establish its efficacy and safety in children. But currently, whatever is available, yes, the ketamine is a safe medication. We can use it with all these principles to in my mind, which we talk about there, the dose, the serum levels, the type of the surgeries, and certainly in setup where you are working in. So thank you very much. I think I am 5 minutes late हो गई थोड़ी सी मैं.
No, you are very much on time. Thank you so much, Dr. Gauhar, for the
Thank you very much.
extended literature, actually literature search, which you have already done. So we have a few questions and comments. Let me check the chat box for your questions and answer session. So Dr. Mohammad Yasser has asked, how can one differentiate in the immediate post-operative period pediatric patient to be in pain or dysphoric effects?
Okay, so as I told you that pain assessment, the challenge is universal and we are not touching in this topic. So in dysphoria, normally, so mother is the first person who pick up that this is because whenever the kid is in pain, uh, though normally वो रोते हैं, whatever expression the mother knows about that. So say said that the dysphoria अगर 10 साल से कम के बच्चे हैं, there's a mother who will guide you कि नहीं इसका कुछ behavior normal नहीं है. If the bacha is crying and complaining or अपना tantrum throw कर रहा है, that's a part normal if he or she is in pain. But dysphoria, whatever literature is available, कि dysphoria with this 20 to 40 microgram में unlikely है कि dysphoria हो. But अगर है भी तो वो time limited, there is no need to do anything. Don't disturb that. वो बच्चा automatically is a short lived and self-limiting side effect अगर होता भी है, so it will go away. It is a short-lived and self-limiting.
So we have another question. Dr. Ali Abbas Rahat. He's asking about, can we use the intramuscular IM for circumcision in children, or IV is the best?
सो करंटली जो कॉन्सेप्ट है आईएम वर्सेस आईवी का, सो जो मेडिकेशन
Dr. Gauhar, I'm really sorry. I am interrupting in between. Actually, we have few participants who do not
Okay, okay,
understand
okay,
Urdu.
okay, okay.
So
So,
I would
so
request you to.
Dr. Now I understand. So, Dr. Asma is talking about which route is better. So, the better route currently, it is the IV route is more predictable route. So, if you are using it for pain management in circumcision, so certainly and circumcision is a small procedure, and you will get the peak level and the desired time, and it will affect it will prolong the post operative immediate period. So I think IV is the best. However, and I don't see any reason why we do the IM, because IM is a painful, unpredictable circulation and painful on injection. And normally, the one of the fear in the past literature, if you see in children's pediatric anesthesia literature, you see that the IM injection is one of the things that the kids really hate. So I'm not saying that the IV cannula is the kids like it, but if it is a place, and we normally one of the mandatory requirement that you have to have one IV line. So if you have one IV line, so IV is the best way route to give ketamine.
Okay, so we have, oh, great. We have Dr. Khalil Shibli with us. Dr. Khalil, you can actually unmute your mic, and he has a comment actually. Preservative free ketamine is available in Europe for caudal adjuncts for pediatric patients. Dr. Khalil, are you there?
Yeah, thank you very much. First of all, thank you. I really enjoyed the talk. Number one, I'm on the move. I'm in the car, but I heard all the in between everything. No, I was asking if it is included in the new guidelines, or because it's an old thing I'm talking about. Maybe quite a number of years ago, we used it was a big 10 mils ampule with a preservative-free ketamine used for children for caudal blocks with local anesthetic sparing effect and a good post-operative pain relief, no doubt about it. So I was asking, what is the place now? Gauhar, did you find anything highlighted in the new guidelines
Thank you very
at all?
much, Shiv. So first of all, I told on this forum that
Did you hear
there.
me?
Yes, I heard. Yes,
Can you
thank
hear
you.
me?
Thank you. Yes, thank you. Thank you, Shibli.
Thank you,
Thank you.
Dr. Shibli. We can hear you, and we have taken your question. And Dr. Gauhar is still on board, and she is answering
Thank
whatever your comments are. Thank
So,
you.
Shibli, I was very focused on my two or three questions. So, whatever literature and available thing, I focus on the systemic ketamine, especially the IV, IM, and nasal route. So, I did not access specifically. I did not search the literature for caudal ketamine, but while going through the guidelines, I did not find any such thing that a caudal ketamine. But you are right that we were also, when a resident, we heard about that, and maybe one or two paper I also read, but not currently. I'm talking about 98 and 99. But current guidelines may I did not find such thing, but I must I must say loudly that I did not search literature for that particular the regional use of ketamine. I did not use. I just see the systematic use of the ketamine for this particular today's topic.
So
Assalamu
we
alaikum,
next.
Meena from Lahore.
Uh,
Gauhar, thank you very much. It was a very informative talk. I just want to say from this forum, how about launching the lollipops, these ketamine lollipops for the youngsters? Maybe it can help us out in managing all the anxieties of the children and the mothers.
Dr. Leena, thank you very much. आपने join because so Dr. Leena, actually, I also talk about that because we are nowadays we are making the syrup of ketamine with the ruafza and all these things. Our pharmacy made it, but certainly we can talk to them about this lollipop. Then we have to see the concentration, all these things. Currently, whatever I find from the literature, that the serum level 100 to 200 are safest, level in pediatric population. So certainly we can guide our pharmacy people that if the concentration of that lollipop using in a minute drive manner. So if it is not exceeding 100 to 200, certainly why not? Because this is one of the recommended route. The oral, nasal, IM and IV route are the recommended routes, so it can be used. It's a wonderful idea, but certainly we will try our pharmacy people because they're using a very sweet, syrup, and the kids like them.
Thank you, Dr. Leena, for coming online, and thank you, Dr. Gaur, for the extensive answers. So next we have Dr. Hagdad Durrani, who's probably asking because he just wrote, not in the question form, that ketamine is partially reversed by naloxone and aminophylline, 1 milligram per kg over 5 minutes. So I don't know whether this is his comment or he wants your comment on that.
So, Asma, as far as the literature is concerned and whatever understanding I have, the ketamine is a non-reversible agent. This is, I think, if from my today's talk, it's one of the take-home message apart from the 5 nodes of the mechanism of action. So because it is a non-reversible, whatever I found it. So if Dr. Huck can guide us, they found that some kind of a personal experience, or if they have some papers, because I did not see any anti-ketamine NMD receptors antagonist in literature.
All
So
right,
maybe
thank you.
if he
And yeah, and we also have Dr. Shahid Dar, who wants your comments on post-operative block and ketamine to be neuroprotective among the other agents in anesthesia.
Post-operative?
Ketamine used in as a post-operative block. Ketamine has a neuroprotective
regional
role.
block.
Yes.
Regional block. Actually,
Probably.
again, I'm saying because my focus, I'm working currently. My working is a systematico. I am not focusing that regional block, but because Dr. Dr. Shibli said that, and now you are said that, maybe I look out that what is the role of ketamine in peripheral nervous system, because we're talking about the peripheral regional anesthesia. So the peripheral nervous system. Shibli was talking about the central, the caudal blocks. So that I have to see that how does it affect. But peripheral, I have no idea about that. So maybe this is a new area that I have to work on it, and I have to see how does it the ketamine as a co-analgesic in peripheral nervous system for regional anesthesia can work. But currently, I don't have any such knowledge.
Right. So we are also skipping Dr. Sadam Mushkaq's comment on your personal experience of ketamine in caudal. But we have Dr. Ali Sarfraz comment. He's asking about the role of ketamine in infants undergoing laparotomies.
So currently, whatever literature is available is from pediatric population, not mentioning, it's not certainly not the neonates, but certainly, yes, infant, the after 1 month old, yes, there is a one of the paper which I mentioned about 100 to 200 microgram serum level. I think they were infants from 1 year to 3 years, something like that. So yes, not in the neonates, because I really tried to find something in the neonates, but I did not find anything in the neonates. But infants, mean the circumcision and the nasal route and IM route, I can recall that the people are using it for infants and small procedures like hernia and all these things, ketamine.
So Dr. Kirat Siddiqui has also asked the similar question that are there any specific considerations for neonates or infants compared to older children when using ketamine?
So infants, so yes, there are infants available for nasal route, available for circumcision. I could recall the nasal route and oral route for circumcision and for hernia, but neonates I did not find any literature in whatever I searched that and whatever I'm working for last 2 to 3 years. So, but again, these are all my new areas. Whoever asked me, this is for my own learning, my own professional development, the questions the people ask, and I'm not aware of that. Certainly, I will go and read and I will share with this platform. if I found
So Dr.
something.
Muhammad Yasir has also asked one very important question, that does dose requirement increases in opioid naive versus non-naive pediatric population, and is there any delay in awakening in the perioperative ketamine is running ketamine infusion? How early age group we can use, like in
So,
which?
there is no to current recommendation. The current 1A recommendation says that you have to build a serum level. So normally, if you are using it as a sole analgesic agent, then certainly you have to, after the bolus, you have to start the infusion. However, if you are using it as a co-analgesic with the opioid, then certainly you have to you can give as a bolus doses, and then according to the pain assessment and the requirements, you can make a individualized plan. But as far as the ketamine in opioid addict patient, there are some papers, although in pediatric population this is not common. But I was reading some of the papers where in Canada or in some countries where the CRPS, the kids after after trauma of long bones because of the snowfall and all these things, and these kids somehow the physicians, they put them on the morphine or the narcotic, and these patients, when required the laparotomy for some reason or appendectomy for some reasons, that they use in those patients who are taking opioid for some other reasons, like snowfall trauma and all these things, that they put on this. In that case, is that for laparotomy they are using as a sole agent for for ketamine with paracetamol and things like that.
And we also have Dr. Shahid Dar, who has again commented that ketamine is neuroprotective in multiple anesthesia exposure. Dr. Dar, are you still online? If you are, you can directly unmute your mic and ask the question from Dr. Gauhar. And at the same time, I would also like to invite the seniors. They can unmute and they can talk to Dr. Gauhar directly. We have a few seniors from other cities like Dr. Dr. Asia Taki is there, Dr. Athar Siddiqui is there, Dr. Aziza is there, Dr. Almas is there. So any one of you, let me just go through it. Dr. Kashif Maiman. We have so many seniors over here. I'm so excited to have all of you here. Thank you so much for coming online, Doctor. Your comments are welcome, more than welcome. Yes, please go ahead. Whoever has unmuted, Dr. Shahid Dar. Yes, please.
Ma'am, my question was basically about the neuroprotection of the ketamine in multiple anesthesia exposure is also proven. When there are multiple exposure to the, especially in the cardiac surgery patients or the burn patients in the pediatric populations, the ketamine also has a very neuroprotective role. It's also proven. It is another edge on the other multimodal options available. I want your comments about this.
Dr. Shahid, you are right. Actually, if you see that the five possible mechanism of action of ketamine, certainly it will produce the neuroprotection. As far as your specific reference about the multiple surgeries like cardiac surgeries, so I haven't come across, and neither I have my own experience because I don't do the cardiac anesthesia. But considering that the possible mechanism of action, it is a neuroprotection. So because neuroplasticity, central sensitization, all these things, so they are proven actions of ketamine, and for that, yes, certainly it will. Dr. Shahid, is it okay or?
Thank you, ma'am.
Thank you, Dr. Shahid. Thank you very much. This is certainly a new era, and we have to join together in Pakistan and this platform that the commonly available drugs that can be used in our population, especially the pediatric population, the pain-free. So we should all aim for that. And Asma,
we also have Dr. Azhar online. Dr. Azhar, would you like to comment something?
Assalamu alaikum. Very nice talk, Dr. Gauhar. Very practical things you have told us, which are very easily applicable to in our population as well. A comment regarding the use of ketamine as an additive in the peripheral nerve blocks. The available data up till date has not made any recommendation the use of ketamine as an additive with the peripheral nerve blocks. If you are using it with the local anesthetic agent, it will not prolong or cannot speed up the action of the local anesthetic agent. So if you are mixing it with the local anesthetic agent, it will give the same effect as if you are giving the intramuscularly ketamine. So it is not recommended.
Thank you very much, Azhar. Those who don't know about Azhar is one of our faculty who is expert in regional anesthesia. He's our acute pain service faculty, and he's doing a lot of regional blocks and right, left, and center the acute pains. So his comment certainly is very valid even for me as well. So as I told you that I haven't focused that my whole literature for that, and now Azhar I think experienced and plus shared the literature. There is no evidence available for its peripheral use to enhance the peripheral regional blocks efficacy or duration or whatever. Thank you, Azhar. Thank you very much. This is certainly very useful.
Thank you so much. Any other comments? And then we will be wrapping up the session because now it's 1 hour post we started. And we are very much on time. The link has been shared for the feedback. We would appreciate that you will fill in the feedback form so that we can send you the e-certificates. Inshallah, we will be heading on towards the next module, which is on neuroanesthesia module. Wish you a very happy new year in advance and a season's greeting to all of you. Thank you so much, Dr. Gauhar. We are so delighted to have you on board and looking forward to have you more on board on this forum. Thank you so much.
Thank you very much. I thoroughly enjoyed. Thank you very much for the opportunity.
Thank you. Thank you, everyone. Have a good day. Have a good night. Thank you.